So this is a two-center study. We couple the experience that we have done with osteoid osteoma in Rome and in Bologna with Alberto. And initially, let me just step back a little. When we started, we had some questions that we wanted to address. And when we came up with the idea of treating osteoid osteoma, first of all, we actually wanted to understand if it was feasible, and we'll explore a little bit into more details this concept, as well as the durability. One of the questions that I was always asked, how long is going to last your clinical effect? And also, what kind of effect on the bone you will be observing over time. And with this study, we tried to understand all these aspects, and particularly we have a population of patients that completed 3 years follow-up. So starting from the feasibility point of view, of course, one of the first and most important aspects is the location, where the lesion is located, and also the accessibility. It was also raised up on previous talks. Here, with regard to the location, you can see that this is a very superficial lesions, and the distance from the skin is very limited, and below 1 centimeter. And still, you can easily treat. Here, in this particular patient, I had the problem of the folding here, where the air can be trapped. And especially on the far field, because in the near field, if I have the foot completely in the water, there is no problem. But sometimes the far field can still have air. But eventually, this treatment was really easy. As you can see, again, the osteoid osteoma is always visible into the dynamic contrast enhanced MRIs at this highly perfused area. And immediately after the treatment, the nidus was completely shut down, and this is just a reaction of the skin without any apparent damage immediately after the treatment, and also days after. And the pain goes away within days with this treatment. The treatment itself is very fast. It's probably more time for positioning than for the treatment itself. Going to location, here is a good question. How much far beyond the cortical line you can reach? Because once you have a lesion located there and you're coming from outside, how much able you are to penetrate this cortical line? And when you have such a thick cortical line, this is what happens. Here again, the dynamic contrast enhanced MRI study. Immediately after the treatment, you can see that the bone acted as, here I can show you here, bone actually absorbed the energy, but since that was a completely regular bone, there was no deep penetration of the energy. So basically, the energy was totally blocked. And you can see easily here, this is the cortical line there, where the white is, and there was not enough penetration. In this case, the patient had to underwent radiofrequency. Another similar case, something different though. Here is the lesion, and here is the cortical sclerosis. As you can see, if I drain the knowledge from the previous patient, I couldn't treat this patient. But if I can show you something closer, is that this lesion is seated in a portion of the cortical bone where the cortical line, this image doesn't show you very well, but here is spongy. The cortical bone is spongy because it's responding. This is a lesion seated within the cortical space. The previous one was in the medullary space. So basically, the reaction here creates a deformation of the cortical, opens up the cortical space. So in this particular patient, the treatment was nice, as it should be, always. So the nidus was completely shut down. Accessibility. Accessibility is something very difficult sometimes. especially with intra-articular location, like in this case, where basically you touch all over the tuberosities. But with some tricky position, you can open up the articular space and you can reach the nidus, and this is the result after 3 years with complete resolution of the inflammatory changes within the articular space. Another important issue is the durability. How long is going to last the clinical benefit of the treatment? Well, this is closely related to nidus perfusion and control of the disease. What does it mean, control? It means that once you see the lesion, after treatment, you do not want to see anymore the high vascularity within the nidus. So I'm going to show you some cases. For example, this is highly perfused nidus. After the treatment, you can still see something there. Pain-wise, this was exceptional. So patient had pain 0 after the treatment, but the bone was still there after months after the treatment. So there was nothing happening to the bone itself. Another interesting case, again, highly vascular. The vascularity decreased, but not totally. So the pain decreased as well to 0, but the abnormality on the bone persisted over time. When do you see a clear effect on the bone? A bone remodeling and a tissue restoration, it does happen, for example, when the nidus is completely shut down, like in this case, you have the bone restores completely. And for example, this girl had the osteoid osteoma sitting in a growing plate, and after 1 year, the bone was fused without any problem. Here is another interesting case, lot of reaction, and again, when you have 100% nidus perfusion shut down, you have this brilliant result, and the pain scores goes to 0 few days after the treatment. When we consider the outcomes in our series, we have found 86% complete success with MR-guided focus ultrasound treatment. And when we consider the quality of life, we had a significant improvement in quality of life, especially when we consider the nocturnal pain and also the limitation to function, especially for sport and daily activities. Here is the final case with a patient with osteoid osteoma post-surgery. So the surgery didn't really help this guy, but after the MR-guided focus ultrasound treatment, you can see that was completely cured. And so this is a treatment without any adverse events so far, and there is a durable clinical efficacy with a great tolerance profile from this patient. Again, what I learned is that when you obtain a greater than 50% nidus ablation, you still have pain-free population, but if you have 100% ablation, you also get tissue restoration, especially in patients under 18 years old. Thank you very much for your attention.
Thank you.
I believe I'm over time.
You are over time, but maybe chairman's privilege. If there's one question.
Could you just quickly give a summary of the power levels and the treatment time for some of the cases that you presented?
It is very variable because it was also depending on the learning curve period. I tended to use higher power in the range, for example, of 3,000 to 4,000 joules, lasting 20 seconds. Lately, I'm using much less energy, much less, in the range of 500 to 1,000, and few sonications. Sometimes one sonication is enough. And if I can clearly see with thermometry, I'm totally confident with thermometry. Sometimes thermometry doesn't work at all, and I rely on the DQA that I perform, so I'm sure something happened there, and I give contrast and that happens. So lately I reduce a lot the energy because the bone absorbs a lot the energy. You don't need for this kind of lesion to use too much.